Hello, everyone, and good evening. I'm Clara from Healthcare Without Harm Europe, and I'm really happy to welcome you to today's webinar, A Healthcare Sector Perspective on Forever Chemicals. And this event is hosted by CHEM Trust, Healthcare Without Harm Europe, and Tegengif. And we're excited to have such a distinguished group of experts with us tonight to discuss the critical issues of PFAS, or also known as forever chemicals, in the medical sector. These chemicals have been widely used in various industries, also in the medical sector, but their long-term environmental and health impacts continue to raise concerns. And in particular, PFAS are known to pose risks to vulnerable population, including pregnant individuals, infants, and children, to their persistence in the human body. And tonight, we will have the chance to explore the latest scientific understanding of PFAS, case studies on safe alternatives, and EU policy solution to tackle the PFAS crisis. And with no further ado, let's get started with our first speaker, Dr. Jamie DeWitt. Dr. DeWitt, over to you.
Thank you so much, Clara, for that very nice introduction. And just to let you all know, I'm on the west coast of the United States, so it's morning for me, but I'm happy to be here with you at your evening. So before I get started, I just wanted to share a few acknowledgments and declarations. I do have funding to study the health effects of PFAS, specifically effects on the immune system. I study the responses to vaccine antigens. I talk about PFAS a lot, but I also have a wonderful army of people who work with me in my laboratory to help us to generate data on PFAS immunotoxicity. I also want to acknowledge where Oregon State is located and acknowledge the indigenous peoples' lands upon which we sit. So for those of you who aren't really familiar with PFAS, I just wanted to share with you a few highlights of what PFAS are. These are synthetic chemicals, so they were produced by people starting in about the 1930s. This is a very large class of chemicals with a specific chemical definition. The Organization for Economic Cooperation and Development has a chemical-based definition that you can look up if you use a search engine just to look for the OECD definition of PFAS. They can be subgrouped into many different categories. We know the most about the perfluoroalkyl acids, so PFAS such as perfluorooctane sulfonic acid and perfluorooctanoic acid, PFOA and PFOS, are some of the most well-studied compounds, and we have the most health-related data for those particular compounds, so we know the most about their potential health risks and their toxicities. PFAS are found in many different products and processes. You likely have some in your workplace and in your home environment. They are used across different sectors. There are probably 14,000 plus individual PFAS chemicals, and we know that PFAS are used in at least 60 different product categories, not to mention likely thousands of products. So you and the people for whom you care for likely encounter PFAS at work and at home. I wanted to highlight what it means for something to be toxic. As a reminder, toxicity arises from interactions that overwhelm protective mechanisms and that lead to changes at the molecular level that can then present as alterations in phenotype or in physiology. These can be changes in the structure of cells or organs, can be changes in behavior, it can be changes in how various systems respond to stressors. I also want to remind you that PFAS are considered to be chemically inert. In other words, they're not reactive. They're not going to steam, hiss, bubble, or boil, but they can interact with molecular receptors in the body to the point where they can overwhelm protective mechanisms and lead to damage to cells, which can then, as I mentioned, present as changes in physiology. So when I talk about an adverse health outcome, that arises from a molecular interaction of PFAS in systems or cells to present as the health risk that I'm going to define for you later in these additional slides. I wanted to also emphasize that people are exposed to PFAS through multiple pathways and multiple routes of exposure. We know the most about ingestion of PFAS, especially of from ingestion of contaminated water, but we also know that people can intake PFAS through their food. And in fact, if people live in an area without a known source of PFAS water contamination, the diet is likely going to be their largest source of exposure. But there's emerging evidence about risks of PFAS from inhalation and risks of PFAS from dermal ingestion. As you can see here, PFAS can get into our bodies and into the bodies of our families and in wildlife through many different pathways. That means that there are many challenges when it comes to restricting PFAS use, restricting PFAS emissions, and then remediating PFAS from sites of environmental contamination. I wanted to share with you just briefly an op-ed that was published in the New York Times just last week, and I wanted to remind you about what I mean by risk. Risk is a hazard times an exposure. We know people are exposed to PFAS through many different routes, and we're identifying the toxicological hazards of PFAS. So when people are exposed to PFAS, it doesn't mean that they will develop a disease, but it does mean that they can have elevated risks. And when combined with other factors that people experience in their everyday lives, the risks can be greater or lesser for individuals. But I wanted to emphasize this op-ed, and the emphasis here is that we have a lot of data on the health effects of PFAS from epidemiological studies of people and from experimental animal studies. So the accumulating evidence indicates that the health effects I'm going to describe to you are real risks for people who are exposed to PFAS. As I mentioned in the previous slide, our evidence comes from epidemiological studies or people who have been exposed to PFAS through their work or through where they live, but there are also many different toxicological studies in experimental animals that support these health effects. There's a great deal of concordance between the health effects observed in people and observed in experimental animal models. That gives us confidence that these health effects are real health effects and that the risks are real from these various routes of exposure. One of the risks that has been identified for PFAS, and I'm going to be speaking mostly about PFOA and PFOS because, as I mentioned, they've been studied for the longest period of time and we have the most accumulated evidence for them. But PFOA and PFOS have been linked to increased cancer risk. Specifically, the evidence is from some epidemiological studies and experimental animal studies, and kidney and testicular cancer have the strongest links. Fairly recently, the International Agency for Research on Cancer classified PFOA as a known human carcinogen or a group 1 carcinogen, and PFOS as a group 2B carcinogen, that is a possible human carcinogen. There's also risk of developmental toxicity, so risk to the organism exposed in utero or in the womb. The most compelling evidence is from a decreased weight at birth. These come from both epidemiological studies and studies of experimental animals, especially rats and mice. We know that low birth weight can increase risks of other disease across the lifetime. And I want to also point out that there's accumulating data from experimental animals and epidemiological studies that there are other types of developmental risk, such as delays in development, such as increased risk of miscarriage, increased risk of decreased fertility. There's also a couple of studies to indicate that neurodevelopmental risk may also be present in human populations. Immune system toxicity risk, which is the system that I study, the largest body of evidence comes from suppression of vaccine antibody responses. These were first identified in experimental animal models and then verified in observational studies from epidemiological evaluations of people. Some of the data on vaccine antibody responses come from a cohort in the Faroe Islands that demonstrates suppression of vaccine antibody responses. A recent review that was published in 2023 indicated that there actually was quite a bit of agreement among the different antigens used in vaccine antibody studies. So across vaccine types, there seems to be suppression, and children appear to be more sensitive than adults to this effect on the immune system. Another risk another risk of exposure from PFAS is liver toxicity. This presents as increased liver enzymes in the blood. There's also in experimental animal models been observations of liver tumors and observations of necrosis or other changes of damage in the liver. But the liver damage from markers of the enzymes in the blood is what has been most observed across human studies. So we know then that this can signify that there's other types of damage from the liver. There have been some emerging studies indicating that certain PFAS can induce liver cancer risk, and there have been some studies looking at non-alcoholic fatty liver disease or metabolic liver disease in human populations. So there's growing evidence that the liver is a target in humans. And I should point out that early toxicity studies in experimental rodents highlighted that the liver in rodents is sensitive to PFAS, and one of the effects was an increase in the size and in the cellularity or cell number in the liver of rodents. Cardiovascular system toxicity also is a risk, and this largely arises from increased cholesterol, both in adults and in children. We know that increased cholesterol can increase cardiovascular system risks. The experimental animal data actually produces evidence that these compounds can lower cholesterol, and one of the molecular pathways which is affected in this particular outcome seems to be more sensitive in rodents than in people, but we understand that humans have an increase in cholesterol, whereas rodents have a decrease in cholesterol. But what we do know is that we haven't seen any studies that have specifically linked increase in heart attacks or heart damage to this particular health effect. But it is classified as a cardiovascular system toxicity risk because of the risk of association between increased lipids and increased cardiovascular system toxicity risk. Thyroid is also an organ that has been identified as being sensitive to PFAS exposure. This presents as both hyper and hypothyroid in terms of thyroid hormone production. It's been observed for both T3 and T4 thyroid hormones, as well as thyroid stimulating hormone. There are also some evidence that the thyroid gland itself can be damaged, leading to thyroid gland disease. And as I mentioned, there are different types of effects that have been observed across different studies. Regardless, this highlights that the thyroid gland is a target of PFAS exposure. I wanted to provide a little bit of a final thought for those of you who are working in the healthcare sector. In 2022, the National Academies presented a report that they put together after several years of work, the committee working. And this is a guidance for healthcare providers. It does provide levels of evidence for some of the health effects that I've gone through, as well as some recommendations as what healthcare providers can do to provide some elevated standards of care to patients who do have known elevations in their PFAS exposure. If you look at the figure here on the left, you can see that these bars across the top represent different concentrations of PFAS measured in the blood. This report focused on 7 different PFAS, PFOA and PFOS were included. And so if you have a patient who has been living in an area where there's known water or food contamination, it may be prudent to have their blood levels tested so that you can help them to figure out if they need some additional tests to see if there are elevated risks for some of the risk that I've discussed here today. So this is a document that is freely available online. I have it here as a reference on the slide.
Thank you. That's very helpful. What do you think are the biggest misconceptions about PFAS that you encounter?
That's a really good question. I think one of the misconceptions is this idea that because PFAS are inert, they don't pose any problems. We just take them into our bodies and we excrete them and nothing happens. And I do want to emphasize that inert does not mean non-interactive. PFAS, we know, can interact with many different biomolecules in our bodies. We know that they can stick to proteins very efficiently. They tend to stay in our blood because they bind to albumin, which is one of the carrier proteins in our blood. We think that's what allows them to get distributed throughout the body. They do tend to be in highest concentrations in the organs that receive a lot of cardiac output or a lot of blood flow, such as the liver, the lungs, the kidneys. There are scientists all over the world who are looking at what drives these protein binding interactions. And so they're trying to understand what makes a PFAS hop off of albumin and hop onto another protein, for example. I think another misconception is that rodent data are not relevant to human health. That is absolutely not true. Certainly, rodents aren't tiny little people, but the data that we obtain from rodents is extremely important in helping us to understand what types of health risks we might need to look for in epidemiological studies. And they also help us to really deeply interrogate molecular pathways that have relevance or perhaps low relevance to people. My
And
pleasure.
now let's hear from Dr. Jesper Kampmann, who will provide us with a case study on safe alternatives to PFAS in the medical sector. Dr. Kampmann, we're looking forward to your presentation.
As you said, I'm Jesper Kampmann, anesthesiology resident in Amsterdam University Medical Center. Talking about safe alternatives to PFAS. Like Jamie just said about the PFAS not being inert, there's dozens of pharmaceuticals that are actually PFAS themselves, and among them are the anesthetic gases. And what we've looked at is, I think this is also one of the take-home messages, is that there's often in the medical field, there's a lot of ways to achieve the same goal. In this case, safe and effective anesthesia. And there's a lot of choices that healthcare professionals can make to achieve that goal. In this case, for the anesthesia, there's the gases, there's the picture on the right. But there's a lot of different ways to achieve a safe anesthesia, also ways without use of the anesthetic gases. And what we've looked at is, part of it is a scientific part, but also a big part of it is to see how we can promote change on a national level. We did it in the Netherlands, to see how we can influence anesthetists nationwide to reduce their use of the anesthetic gases, which are PFAS. For a short introduction, why care as a healthcare professional? I think, most of us work in a health institution that you can see there in the middle, but and these institutions themselves have a considerable footprint, but there's also the whole processes before energy, electricity, production of all the pharmaceuticals, all their equipment that we use, a lot of transportation, and all of that has a footprint that in turn also creates a health burden. And we want, of course, we go to work every day to create a health benefit for our patients, but we want to make sure that the actual work creates a net benefit on the population level. And that's why I think it's very important to reduce also the pollution that stems from our work. This is a figure from a European project that's looking to reduce the PFAS emissions from the medical sector. And these are the yearly emission estimates in the EU from the health sector. And as you can see, the second largest bar concerns gases, not just anesthetic gases, also propellants for, let's say, pulmonary medications, like for asthma, COPD, but also gases in refrigerants, air conditioning, many different sources. But a small part, but still considerable part, is estimated to be from anesthetic gases. There's three different anesthetic gases in use today: sevoflurane, desflurane, and isoflurane. And this is what they look like, and they're all, as you can see, or else some of you may see, they're all PFAS. And I think this links to the question that was just posed about the grams of PFAS that come from a single bottle of anesthetic gases. So this is a bottle of sevoflurane, which is about 250 ml. which translates to 382 grams. And from that, it's after we administer it to our patients, they breathe it out, and it ultimately goes out of the chimney of the hospital into the atmosphere, where it stays for a couple of years, and then it degrades to a PFAS called PFA, which you can see here on the right. And still from one single bottle, which is about, I'd say, an anesthetist that works with this for all their anesthesia cases, is about a week's worth. So every week you go through such a bottle, and it emits 218 grams of TFA. For the EU, there's this drinking water limit for total PFAS of 0.5 micrograms, which means that this one bottle that emits 218 grams of TFA can pollute more than 400 million liters of water up to that limit, which, if you think in Olympic swimming pools, is a lot of Olympic swimming pools. And that's just from one bottle that one anesthetist will use in a week. So what we do, we try to promote anesthesia without anesthetic gases, or at least a significant reduction in their use. And safe, comfortable, sustainable is the mission statement of our anesthesia department. This is a quick overview of the project. So it was a research phase in which we looked at safety of the different ways of providing anesthesia. If there's a clinical reason in certain situations to pick one of the two. There was a development phase in which we created a national guideline in collaboration with our national society. It's also enforced through the quality control audits. And in the implementation phase was a national campaign that's actually still running, started last year. There's a local protocol that every anesthetic practice in the Netherlands needs to adopt. And in the final evaluation phase, we look, that's where we are now. We're looking at how the intervention is adopted, how effective it is, and also if it has any effect on anesthetic drug usage. So quickly highlight some of these. In our patient safety study, we performed a large systematic review with meta-analysis, which we collected all randomized controlled trials. There was actually more than we expected. So there's still many trials ongoing on the same subject. So we only included trials that randomized patients between either total intravenous anesthesia, so without anesthetic gases, or inhalation anesthesia, so with anesthetic gases. And we looked at a large array of outcomes. We found, most importantly, no difference in any mortality or organ-related morbidity outcomes. So no safety concerns that point either way, which is also part of the reason that both ways are very standard, very commonly used throughout the world, because there's no clear indication that one of the two is better for patient outcomes. Of course, environmental concerns are a newer indication. What we did find was that when anesthetic gases were omitted, that patients experienced less nausea and vomiting, less emergent delirium. That's a kind of agitation on awaking from anesthesia. And their quality of recovery, which was collected through validated questionnaires, was also slightly higher without anesthetic gases. So that actually these, which was a good outcome for our project, of course. We also did an interview study among anesthetists because we really wanted to enact change. We didn't just want to, to write another article that says that that people need to change their practice, but really understand barriers to change and how we can try to address those. And we actually found two main priorities that kept coming up. Number one was patient safety. I think that's very logical for any medical professional. It's the main reason you go to work every day. Just you want and go home with content is if your patient went through their operation safely. But the second one was professional autonomy. So they felt in order to be able to provide safe patient care, they needed the freedom to make their own decisions. So we kept this in mind throughout the whole project. Like I said, in the development phase, our main intervention was a national guideline in which sustainable anesthesia was taken up. So it was a nationwide perioperative guideline. On the right is actually the cover of the guideline, very AI. And the strength of the collaboration with the National Society was that it's by and for anesthetists, so it's through a member consultation round, which we got a lot of comments on, almost 100 comments, which went both ways, of people saying that sustainability should never be a factor in patient care, and also people saying that we were too soft. And we arrived at a middle ground, and it was ratified by the board and also the member council of the society. So it really had that strength behind it. Then for the local protocol and national campaign, what the guideline said was that the default mode of anesthesia in the Netherlands should be the anesthesia without gases, but that exemptions to this were at the discretion of each individual practice and clinic. But it did, every practice needed to adopt a local protocol that outlined how they were going to apply this in their practice. This is also one of the reasons that some people thought it was too soft, because it's not, the enforcement wasn't, it still left room to use these gases at their for clinicians at their own discretion, but also, every practice, all anesthetists that work in a certain hospital needed to sit together to come up with the exemptions that they thought were reasonable. And also based on the interviews that we did, we really thought that this would have a very large impact on the emission of anesthetic gases. So yeah, take home message, I already said one when I started the presentation, that in the health sector there's often multiple ways that lead to a certain outcome. So I think it's very useful to try to find out not just the effect on patient care, especially when that's similar between options. Try to find out what the effects on the environment are, and see if there's a way to, without new ways or new pharmaceuticals, new alternatives, but already existing alternatives can already produce a large environmental benefit when they influence clinical choices. But also with this strategy, to really try it on a national level, try to collect thoughts and ideas, and also barriers to change among clinicians. I think this is a method that can also be copied to other settings as a successful way to reduce environmental burden. Thank you very much.
We actually have to already move on, and now I have the big pleasure to turn to Dr. Shubhi Sharma, who will give us an overview about the solution to tackle the PFAS crisis. The floor is yours.
Hello, I hope you can hear me, and thank you so much for inviting me to speak today. My name is Dr. Shubhi Sharma, and I work at CHEM Trust as a scientific researcher. So CHEM Trust is a charity which works at international EU and UK levels to protect people and wildlife from harmful chemicals. And, today Jamie and Jasper have already talked in length about how PFAS are a group of synthetic chemicals and how PFAS pollution has become widespread across the globe. And there are some serious concerns about the health impacts of PFAS as well. So I will talk a little bit more about what the EU is doing to regulate PFAS and some of the challenges that it's facing in doing so. So there are approximately 10,000 PFAS, according to the OECD, or Organization for Economic Cooperation and Development. And in 2023, there were 5 EU member states, so Germany, Netherlands, Sweden, Norway, and Denmark, which submitted a proposal to restrict the manufacture, import, and use of all 10,000 PFAS in the EU. And this restriction proposal is also commonly known as the universal PFAS restriction, or more colloquially as the UPFAS restriction. And there are many uses and applications of PFAS which are covered in this proposal, and different uses have been given different deadlines to transition to PFAS-free alternatives, depending on how readily these alternatives are available. So medical uses have been given up to 13.5 years to transition. There are some parts of the industry which argue that the UPFAS restriction will lead to a socio-economic crisis. But what's really important to understand is that the UPFAS restriction is not a blanket ban. It is actually quite pragmatic, and it gives enough time to various uses of PFAS to transition to PFAS-free alternatives. It was earlier this year that there was a project called the Forever Lobbying Project, which was an investigation between 46 journalists and some academics from across 16 countries. It's called the Forever Lobbying Project, which revealed that there is a coordinated industry lobbying campaign which is seeking to weaken the proposed UPFAS restriction. And so what some of the industry sort of argue to justify the continued use of PFAS is that they say that PFAS are necessary for patients' continued healthcare because there is a lack of alternatives in the medical sector. But like Jasper has already shown, alternatives are already up and coming, and we believe that the UPFAS restriction, it gives enough time to innovate alternatives and other medical uses as well. There is another common argument which is made by some parts of the industry, and I could see some of the questions being asked in the chat is about fluoropolymers, and that they should be exempted from the scope of restriction because they are harmless. So fluoropolymers, they're a type of plastic PFAS, if you don't know what they are. And the most common example is Teflon, so your non-stick coating on your non-stick pan. And fluoropolymers, they have a very wide variety of uses, and they're also used in medical uses, some of the uses which Jasper already highlighted. So, like I said, some of the industry, they argue that fluoropolymers are harmless, but there is actually independent scientific research which shows that fluoropolymers are much more problematic than the industry likes to claim. So the main concern with fluoropolymers is not when they are being used, but rather it is during the manufacturing stage and during the waste stage. So for instance, if you take the example of a non-stick pan, so when you're cooking on this pan, that might not pose a huge health risk to you, but when this pan is being manufactured, it's during this process when there will be a lot of harmful PFAS which will be emitted into the environment. And again, when this pan, it goes into a landfill or it's incinerated, when its life comes to an end, that's when a variety of harmful PFAS will be emitted. And the same is true for other fluoropolymer containing products as well, including medical products. So fluoropolymers are actually quite problematic PFAS. But unfortunately, the result of such industry lobbying has been that decision makers have been receiving mixed messages about the harms of PFAS and the availability of alternatives. And this is one of the reasons why the proposal has been weakened and the transition to safer alternatives has slowed down. So Jasper's case study demonstrated already that PFAS-free innovation is already happening in the medical sector, but we need more such examples. We need a collective evidence-based front to show that alternatives to PFAS exist in the medical sector. And you in the audience, you can support this by connecting with Healthcare Without Harms networks and with other national networks like the Green Health Alliance in the Netherlands. You can actively demand PFAS-free products from suppliers and from manufacturers. You can talk about PFAS, you can raise awareness, you can encourage suppliers to provide PFAS-free options, and you can share knowledge about existing alternatives. We work closely with decision makers, and we can provide you opportunities to deliver your message to them. So do get in touch if you have any interesting stories about PFAS-free alternatives in the medical sector to share with us. And the more examples we gather, the stronger our collective influence on policy and procurement decisions will be. And together we can really show the policymakers that a transition to PFAS-free economy is feasible and absolutely necessary. So just as a closing message, we cannot allow the powerful industry to lobby to define the future of patient safety and environmental health. The healthcare sector must be led by example, by sharing knowledge, by demanding change, and by demonstrating that PFAS-free alternatives exist in the medical sector. And this is the only way to protect ourselves and the future generation from the adverse impacts of PFAS.
So I think with that, I'm wanting to thank all my wonderful speakers. It was really, really lovely to have you and so much insight. I also always learned something. And also, if you have further questions, feel free to reach out to any of the 3 organizations that work to organize it. So either Healthcare Without Harm, CHEM Trust, but also Tegengif. And I also wanted to send a thank you to all my co-organizers that made this wonderful webinar happening. And with that, I think we can close the session. Thank you so much. And I wanted to remind you once more if you want to if you want to stay in touch and work on this issue, please connect, write us a mail, fill out the SurveyMonkey, and we can work further on this really important topic. Thank you so much also to my speakers.